Hi everybody, we're going to cover Chapter 9 on Airway Management. So some physiology, a little bit of review on the airway. The upper airway begins at the mouth and the nose. So as I've talked about before, when the whole purpose of that is when air comes in the nose, it humidifies everything. You remember talking about the discussion on whenever you have that stuffy nose and how dry and sore your throat can get, because it's not humidified, it's just dry air you're breathing in through your mouth. So the pharynx is composed of three different parts: the oropharynx, nasopharynx, and laryngopharynx, all that ending at the glottic opening. At the glottic opening, that is where your epiglottis is. Remember, the little valve that keeps everything from going down the wrong hole. So as you see here, your nasopharynx. This is all the nasal passageways. This is where the air comes in, hits these turbinates, and it flows there all the way down. So your nostrils, all the hair filters out all the dust and debris, and it humidifies it, so it's nice humidified air going down so you don't get that sore throat. The oropharynx is the oral way. This is just your mouth. And the laryngopharynx is in this area here just below the oropharynx. So I'm sure you've all heard of laryngitis. So with itis meaning inflammation, that would be swelling, inflammation of the laryngopharynx. And here you are at the glottic opening. Your epiglottis over your vocal cords and your glottic opening. So the lower airway begins below the larynx. The larynx being that bony, rigid surface midline of your neck. And that is the trachea, the bronchial passages, the first big tubes going down in the lungs, and the alveoli, where all that gas exchange is happening. So you see here your first part of your bronchioles. Your trachea is going down in, this is the main tube going down in, this is your airway hole. So everything splits into your left stem bronchi and your right stem bronchi. As it goes down to the very smallest part of that is the bronchioles. And then at the end of those bronchioles is that alveoli. So those alveoli, they're in a grape-like sac cluster. There's a whole bunch of them tied together. The whole body has on average about 300 million alveoli. So the alveoli, as we've talked multiple times, but it's good just to remember all this, that where all the gas exchange happens. The alveoli, the capillary vessels that surround the alveoli, the oxygen comes in, the CO2 and other waste products offload. So here's just an illustration of those grape-like clusters of the alveoli. You'll just see here a whole bunch of them all at the end of those bronchioles. Now this is very, very, very small. They're not actually truly the size of a grape, but they're very, very small. This is at the microscopic level, but this is where all that gas exchange happens. So another illustration of the alveoli. You'll see here on the left, you've got the bloodstream in, the capillaries that surround those alveoli. So over here is, as I've talked about many times, that river coming through, the barges coming in, the oxygen's coming in, the CO2 is going off of that cell, and that's what we're exhaling out. But if there's damage to this alveolar space, that could prevent that CO2 from getting out or even the oxygen from getting in, such as chronic airway issues. Or, as I've talked about, if there's a clot or something here that prevents any blood cells to get through for the oxygen to get onto and the CO2 to offload. Airway obstructions are something we've always got to be precautious about with the patient. So that could be acute or chronic. Acute meaning a short onset, happened all of a sudden, not there all the time. Such as the guy who's at KFC, ate the wings and the bone and everything and is now choking on it. To such things as vomit, you've got the frat boy passed out drunk, laying on his back, throwing up, and the vomit's in his airway, and he has this decreased mental status, and with that, he can't maintain his own respiratory drive or be conscious enough to roll over and let the puke go out. Also, such things as facial trauma. You get blood in the mouth, you get that person who got involved in a vehicle accident, got blood in their mouth, they're unresponsive, they can't clear it out, Also, other things going on with teeth, other particles, and everything else. Now, some things that occur over time, maybe a little bit closer to a not acute stage, would be such as edema from burns. A patient who gets burnt in the face, around the neck, ends up causing major swelling, some fluid shifting, and can end up completely compromising the airway. To the trauma patient, as we talked about, getting blood, teeth, stuff like that in the airway that could compromise it. Also consider the traumatic airway as the gunshot victim who just got shot by a high caliber pistol in the neck. That could be a major traumatic airway issue. Also stuff like infection, anaphylaxis, the guy who just ate the shrimp and now his throat's swelling up. All those things can really obscure and constrict the airway, causing some major airway. Another one you'll see very routinely is bronchoconstriction. That's those bronchioles, that left and right main stem bronchi. Those things will constrict down. So you think about a larger airway that's open and now it's constricting, getting smaller, whether that's from an allergen or anaphylaxis or an airway exacerbation such as COPD, asthma, emphysema. All those kinds of airway issues can end up causing bronchoconstriction. So if you think about that like the end of a balloon, whenever you blow up a balloon and the valve of it, you pull really tight, the air barely just squeaks out. And that's exactly what the patient's doing. The air's trapped in their lungs and you just got that valve barely squeaked out. So that is the bronchioles constricting. Airway is one of the most important things you have to assess in the patient. So that's all part of your primary assessment, monitoring your airway, breathing, and circulation. Airway is generally coming first. So you need to assess if the patient even does have an airway. As subtle as that sounds, it's one of the most simple things you can do. First thing, you open that line of communications with the patient, saying, "Hi sir, I'm so-and-so from EMS agency. How are you?" Or "Why'd you call today? How can I help you?" Anything, get them talking. So if they reply back to you in a full sentence, it lets you know they have a patent airway. But if they start saying it in just 1, 2, 3 word sentences before they have to take a real big deep breath saying, "Well, I called you because I can't hardly breathe," that could be a very big indicator that that's maybe not a good patent airway. So all part of that primary assessment is analyzing, is that airway open? Is it going to stay open? Is this patient going to go into respiratory arrest? How critical is this airway? Because that's one of the most aggressive things we have to manage on the patient. So once again, one of the best ways to determine the patient's airway is to make them talk. Make them say hello, say, "Hey, what's going on today?" or "How can I help you?" Some way, if you're able to talk, you have an airway. Once you've determined that they do have an airway, it's not just a one-time thing like, "Yep, they're breathing, they got an airway, I'm done." You always have to keep an eye on it and always be given that constant attention. For example, I had a guy who was highly intoxicated one time, checked his ABCs, yep, he's breathing, lungs are clear, all is good. On the way to the hospital, he was so drunk, he just completely quit breathing. So it's one of those things you just got to continually keep an eye on and also be analyzing once you do determine how patent the airway is, to be thinking about your mind, am I going to have any major airway issues with this guy or girl for that instance? But all that goes into if you're going to be needing any backup, or if you need to call a paramedic, or if you need to get an extra hand in there, somebody to help you of how bad this airway situation could be. So signs of that inadequate airway. So when you've determined that it's patent, you got your A's, there's an airway. Now to be checking for breathing. How much are they breathing? Is it too fast? Is it too slow? What exactly is going on? So some indicators of that is, for one, if there's no signs of breathing, if they can't talk at all, there's no air movement, that's a bad day. Also, if you don't see any air movement, feel any air movement, you don't see that chest rise and fall, or you maybe only see one side of the chest move, not the other. Difficulty speaking, if you hear that hoarse, raspy sound, which could be an indicator of an upper airway issue, such as the person that has laryngitis, they just sound really hoarse and raspy. There's major upper airway issues. So thinking about upper airway stuff, a patient who's choking, that's an upper airway issue, could end up having that hoarse, raspy voice. Also, if there's been trauma to the airway, they'll have that same voice. I've had patients who've had trauma to the neck, say from a vehicle accident, fuller accidents, and they sound really raspy. They'll have a really just an odd off-the-wall voice, and they'll know that their voice isn't the same. Also, if you see the patient positioning, whether they got their head in the air, in a sniffing position, that nose straight up in the air, their body's trying to compensate, come up with other ways to get more air in. If they're doing a tripod position, which would be in a sitting position with the hands on the knees, leaning forward and doing that head bob, or if you see that they're using any kind of accessory muscles, say if they're using their stomach to breathe a whole lot, or you see intercostal retractions, those muscles in between the ribs sucking in, the muscles up around the neck. If you see any of that stuff being used and straining, bad indicator that somebody's having some major airway issues. Also, if you hear any crazy noises coming out and you don't even have a stethoscope out yet, so if you can hear that wheezing or just a high-pitched kind of almost a scream coming out of them, that's major stuff if you can hear airway issues without a stethoscope. Also, you hear those, as we call them in the field, death gurgles. That's that patient who's got fluid buildup in their lungs that it's basically seeping out their mouth and they're almost drowning from the inside out. Also in the kids, if you start to see the head bob, nasal flaring, muscle retractions, that's extremely bad on those kids. Once the muscles start around the area of the lungs, and once the muscles expand further than that, say up to the neck, or you're using muscles furthest away from the lungs, say in your head, your face, your neck, once you're using all the muscles you can, if that's still not solving the airway issue, that's a very bad day that somebody's in immediate danger of potential respiratory failure. So opening airway, one of the most simple things you got to do to manage somebody's airway is you have to open it if it's not open. If they don't have a patent airway, we must give them one. So if your primary assessment, you check your A's, hey, how you doing? Why'd you call today? And you got nothing. They're there unresponsive. You need to go mainly open up the airway, because without the airway, you're not going to live. So a couple of things you just need to do is just, for one, reassure that it's not a traumatic injury, because the last thing we want to do is run up to a trauma patient who doesn't have a patent airway and then jerk on their head and injure their neck. So if there is any suspicion of head, neck, or spinal injury, there's some things we have to be very cautious of. So the most formal thing we do to open somebody's airway in a non-traumatic situation is the head tilt, chin lift. And the other maneuver we use for traumatic situations is called the jaw thrust maneuver or the modified jaw thrust. The head tilt chin lift is pretty self-explanatory. You just take the head, you tilt it, you take the chin, and you lift it. The head tilt chin lift. Yes, EMS isn't always full of the most biggest rocket scientists in the world, so they like to keep everything in the KISS principle. Keep it simple, stupid. So you just take your hand, put on their forehead, lift on the chin, be sure that your fingers are on the bony part of the jaw. You always want to make sure that, because if you don't push on the bony part of the jaw, and you end up pushing on the soft tissue below the jaw, you can end up shoving that tongue backwards into the airway. And remember, that tongue is the biggest obstructor of the airway, especially laying on the back. So just some step-by-step procedures. Put your hand on the forehead, gently take your fingers, put them on the jawline, lift the head up to where that mouth is straight up in the air. So you want that mouth in that a neutral sniffing position, just the same plane you'd be if you were standing straight up facing forward. You want their head to look in that position. That'll get the tongue lifted up off the back of the airway and open it up. Sometimes with patients, that's all that it takes. I've had patients before where they were laying on the ground, not breathing, just manually open their airway, simple head tilt chin lift. They just start breathing again and they come back. No more treatment necessary. Sign here, my service is done. So the jaw thrust maneuver is a little bit more complicated. In this situation, we can't be rocking on the head because we're fearful of a cervical injury. And the last thing we want to do is that they don't have a patent airway, so we paralyze them. So what you're going to do here is you take your thumbs, as the image on the right shows, you put your thumbs on the cheeks, and you take your other fingers and you put them on the hinge part of the jaw, right where your jaw makes a bend. So everybody just go and feel your jawline now. Feel where the little bend is, where the guy's fingers are. And you'll basically take that and you'll kind of want to squeeze your thumb towards your fingers. And that's basically going to lift that jaw straight up in the air. That too will be freeing that tongue up off the back of the throat. Step-by-step instructions for those more reading learners. Keep the patient's head, neck, and spine aligned. You want to maintain their cervical alignment. So as you're using your hands to stabilize the head, you're also going to be using those hands to be lifting up on the angles of that jaw. But we need to be sure that we're not rocking that head, not manipulating the neck in any way. Everything's in a neutral position. Keep your fingers at the angles of that jaw, straight up in the air. Keep that head still. So now that you've got an open airway, you must maintain it. So there are some things that can go into that. Once that's open, you may find that they've been choking, they've got vomit, they've got food, they've got something else in their airway that needs cleaned out. So we can do some different things. We can suction it. We can put in some airway adjuncts. There's a lot of things we can do to make sure that airway stays patent. Because once you've done a head tilt chin lift or the modified jaw thrust, you've got to put something in there to keep a tongue up off the back of the throat and make sure the airway you just worked so hard to make patent is going to stay that way. So we'll talk a little bit about airway adjuncts. These are what's going to assist you in keeping that airway open. Opening that airway manually, that's just a temporary thing. That's a really subtle maneuver that you did, just a baby step in the right direction. So once you've got it open, we need to do something else to make sure that they're still getting in the appropriate amount of air volume that they're going to get. So two most common types of airway adjuncts is an oropharyngeal airway. And from medical terms, we know that that oropharyngeal way, that's in the airway, that's via the mouth. So common term is OPA. Nasopharyngeal airway, as we learned in the first slides, that's in the nasal passages. That's an MPA. So yes, we're going to shove that in their nose. A very important rule that is often skipped. As I said, sometimes just manually opening that airway can do the trick, and that may be the result of the person just coming back. Had it happen with the patient, unresponsive, manually opened the airway, came to life, almost like a poltergeist kind of thing, kind of creepy, but it worked. So that you've got it open, the thing you want to do now is you're going to be looking for an OPA. That's what you want to go to first. It's going to get that tongue up off the back of the throat, but the only real contraindication for that, meaning a reason why you can't do it, is if they have a gag reflex, because that's the last thing you need to do is shove an OPA in their mouth. They start to gag and then they throw up, and now you've got an airway compromise. So you need to be sure when you put that in that you'll take the proper steps, which we'll go over here shortly, and how to insert the OPA, preventing from pushing the tongue back in, just going against everything you're trying to prevent. Whenever you are managing an airway, you need to be sure you have suction available. Those are mounted on the side of the ambulance or in portable units, just in case the patient does begin to vomit or something. Most of the time, if you have to be very aggressive with the patient's airway, there's going to be stuff you have to suction out. 9 times out of 10, there's always something. You know, if you put in an advanced airway, which we'll talk about those a little bit later, there's always a stimulation in the mouth that there's a lot of saliva production. So you're going to even have to suction that out. So 99% of the time you manage an airway aggressively, you will be suctioning out the airway. As I said, if you're managing the airway, you need to have that suction ready. So in the ambulance, that's generally where you always find the suction units, is up near the airway seat. So in the ambulance where the cot is, there's a seat right above it where the patient's head would be. So that's where the person managing the airway is going to sit, and that's where oxygen, the suction systems, and everything are at, right beside their head. So if you do put that OPA in and they, everything is going great, you're bagging them, you got all the saliva suctioned out, but all of a sudden now you've improved it and they're becoming more alert, and all of a sudden their gag reflexes came back. If they start to gag, you must remove that OPA immediately. Once again, we don't want people on their back choking on their own vomit. And if you're going to be in that airway seat, most ambulances I've been on next to that airway seat is also some face shields, more gloves, things like that. Last thing you need is fluid coming out of that patient's mouth and into your mouth or your eyes. That's just kind of nasty. So here's an animation, not an animation, but a illustration of an OPA and its use. You see in the top picture here, patient's laying down, their airway hasn't been manually opened yet, and that tongue's laying on the back of the airway. So in the lower picture, their head's been positioned, head tilt, chin lift, the OPA has been inserted, and it's in a J shape. So that J shape will go in behind the tongue, and it keeps that tongue lifted up. And these are examples of some OPAs. They come in multiple sizes. You see they're ranging from wee little mouse up to really big mouse. And they're just hard, rigid plastic with a small, thin flange in the middle. So it doesn't really obstruct the airway, doesn't prevent any kind of volume issues. It just provides some structure, keep that tongue up, and still allows air to go in around its structure. When you want to select what size OPA you use, really simple step. You take the OPA, you measure between the edge of their mouth and the tip of the earlobe. That is just a general rule of thumb to sizing an OPA. Pretty quick. Most kits that are on an ambulance, there's 5 various sizes, and on adults, you're either at generally the biggest one or the second biggest one. Then little kids, it varies in between there. When you insert the OPA, the patient needs to be on their back. And be sure once again that you've manually opened the airway. So once you've manually opened the airway, they're in that sniffing position, or you've done the modified jaw thrust and you got that airway patent, you need to open the mouth. So you'll use that doing a cross finger technique or a scissor technique to get the mouth open up so you can get that OPA in. And when you put the OPA in with that J shape, you don't want the tip to go just straight down in. You want to start it out with up towards the roof of the mouth or just slightly to the side, and you kind of put it in with a twisting motion. So you see here in this picture using the cross finger technique, pushing against their teeth, getting their mouth open nice and wide so you can get that OPA in. So once again, that's called a cross finger technique or the scissor finger. It's got a couple different names, but it all does the same thing. You'll start the OPA in with that tip along the roof of the mouth. As it gets in towards the back of the pharynx, you're going to start turning it. So that way that point is getting behind the tongue. So whenever you go to turn the OPA, it's basically just going to hook in straight behind the tongue, and it goes and lays in, keeps that tongue lifted up, and the flange of it will go up against the patient's mouth because it's got a wide flange so they don't end up choking on it, going it down too far than it needs to be. So once you get that in, you just need to keep an eye on them, making sure that they're not redeveloping a gag reflex or something that could really end up compromising the airway. So you see here, you got the cross finger method happening, or scissor method, whatever you want to choose to call it. You got the tip of the OPA in, and once that gets in, about halfway is when you're going to start to turn it, and it'll go behind the tongue. With nasopharyngeal airways, NPAs, they're going in the nose. They're basically just a soft rubber tube that's also called a nasal trumpet. You'll hear that called by some of the older folks in the field. but it's just soft as rubber. It's flexible, pliable, so it can go in and follow the curvature of your nasopharynx on the way in. And it'll go in behind the tongue, once again, just to be able to help with the airflow getting in. So the reason you'll want to go and use this is if you've put in that, you try to put in the OPA, and they've got a gag reflex, or their jaw's clenched, or for whatever reason your cross finger technique won't work and you just can't get that OPA in, then you'll use the nasopharyngeal airway. A contraindication for it though is any kind of facial trauma. So if they've got blood or any other kind of fluid coming out from their nose and ears and a sustained head trauma, you don't want to put in an MPA, because if they do have some kind of a skull fracture, you could shove it in the nose, push it through the fracture of the skull, and poke them in the brain with a rubber hose, and you don't want to get into that mess. They do come in various sizes, the same way as the OPAs, except there's generally a lot more to choose from, but the most common are 34, 32, 30, and 28 French. Now, what the French measurement is, I'm not sure, but that's just the standard that some other airway stuff is measured in. So the bigger the number, the bigger it is. So when you go to put in the MPA, you need to measure it too, and you're also going to lubricate it. Generally, every package of MPAs comes with a water-based lubricant just to aid it going in the dry nose. So you'll measure it just the same way that you do the OPA, but since you use an OPA to go in the mouth, the MPA goes in the nose, it's only appropriate you measure from the nose to the tip of the ear. And you can kind of see in the picture there how it'll go in and align with the curvature of the nasopharynx and go right in. You'll want to use that water-based lubricant. Get it nice and lubed up. So those things come in a plastic package. So sometimes the ambulances just have a standalone lube container that you can squirt in the package that the MPA comes in, and just twirl around in it to where it's all coated, and then it'll go right in. Unless it's a patient you don't really like, then you can put it in without any lube and just dry pop it and really irritate them. You'll see in the picture here that there's a bevel on that MPA where it's got a slight cut. So that side, whenever you insert MPA, that needs to go towards the septum. No matter which side you put in, that bevel goes towards the septum, that middle ligament that's in the middle of your two nostrils. So you just want to push it in. Generally, you want to start on the right nostril, just because all studies show anatomically that everybody's right nostril is slightly bigger than the left, so it'll aid with everything going in. So if you can get it in the right nostril, is the way these are designed, going in the right nostril, that's a bevel side towards the septum, just in a natural curve as the nasopharynx would be, and you just put it in until the flange goes up against the nair. Now if you have to put it in the left side to get that bevel towards the septum, the NPA is going to look like it's upside down. So you'll kind of put it in as a twisting motion as well. Very important thing you need to do to be managing this patient's airway. Anything that's obvious in there that you need to get out, you need to get it out immediately. So if it's blood, saliva, vomit, mud, whatever's in there, you got to get it out. So basically a suction is just a little mini medical shop vac. So you're going to put it in there, and you're going to suck out a whole bunch of fluid and whatever else you can to get that patient's airway open. They come in a mounted system, which is obviously mounted in the ambulance, and since you can't take an ambulance into the house, they also come in a portable version. But the mounted suction systems, as I said, they're up by the airway seat for the person managing the airway, has easy access to it. Also with that, you're going to want to have a bottle of sterile water, so if you get thick stuff sucked up in it, you can use that sterile water to flush it all out. So there's also regulator valves on it to set the appropriate levels of suctioning pressure, because if it's a little kid, you don't want to create as much suction pressure on them as you would an adult, or you could end up sucking them inside out. Not really, but you would get the point. The portable ones basically do the same thing as the wall-mounted ones do. They just come in a portable form, and most generally they're battery powered. There are some out there that are oxygen driven by portable oxygen tanks, or even manually that you got to squeeze, create pressure, but those don't work nearly as well as just the battery powered units do. They're comprised of multiple parts. You've got the tubing, the suction tips, the suction catheters, and the collection container, what all the bad nasty stuff goes into, and then always generally with them is that container of sterile water. So once you get, if you have to suction out any thick stuff and it gets lodged in that tube, you suction in the sterile water, flushes out the tube, builds up your suction pressure once again. Here's an example of a wall-mounted suction unit. You'll see here you've got the regulator up here. Green's good, red's bad, that you adjust on this knob here. So here's your container that all the bad nasty stuff comes into. So you'll see here a tube goes from it into the wall suction unit, and then another tube here goes to the patient. The tubing to this hard plastic tip here is what's considered a yonker tip or a rigid tip, and that's what you're going to use to put in their mouth and suction out all the bad stuff that you need to. So with tubing, tips, and catheters, that yonker tip is by far the most common one. And generally all the pre-packaged tubing kits, that's what's in there as a yonker tip, just because it's a lot more user-friendly. It's got a large orifice in it, so you can suction out some pretty thick substances. Here's an example of that yonker tip and how you would put it in. So when you put it in, you generally don't want to push it back down in any further than you can see, because the last thing you want to do is be shoving it all the way down into here to where you can't see, and they're actually choking on something. You shove it down in, and you shove that chicken wing all the way down and make that choking patient much worse. So like I said, suction only as far as you can see. Don't ever lose sight of the tip of that thing. You don't want to shove it down in there too far. If you shove it down there too far, that can initiate the gag reflex as well as vagal stimulation. And what that vagal stimulation is there's a nerve that runs along the back of the throat. If you hit that, it can end up making their heart rate drop and just make the patient's condition way worse. There's also flexible suction catheters. Those are designed if you can't, it's an application that hard rigid yonker won't quite work for. So say if you've got an MPA in, you need to suction out the nose, you can put in that flexible suction catheter into the middle of the trumpet and suction stuff out of the nose, or you can put it into, when we talk about advanced airways, you can shove it through the tube that's in, whether the EMT puts it in or it's an intubation tube that a paramedics put in. You can just put that soft suction catheter down into the tube to suction out more of the airway again. Once again, with stuff kind of dealing with the airway, those suction catheters are sized in a size of French. The bigger the number, the larger the catheter. Now, most of the suction catheters aren't big enough to suck up really, really thick stuff. So if it's teeth, a whole chicken wing, you're not going to suction that stuff out. It's truly not a shop vac, but when it comes to vomit, saliva, all this stuff, it'll work really well. So one thing you can do if it is really big stuff, if they eat chunky vegetable soup and there's big thick pieces of stuff down there, you can actually take you can take that catheter off and just use the suction tubing itself. It's a much larger orifice and it'll do basically the same principle. That flexible suction catheter is measured out and sized out the same way as the OPA. If you're going into the mouth to suction stuff out, from the tip of the mouth to the tip of the earlobe. As you see here in this picture, measuring out that soft suction to the ear to the mouth. And a lot of those soft suction catheters will have numbers on them. So you see the one in the picture here does not have any numbers. But the ones who do have numbers, once you do size it up, you can just see the number, so you know when you insert it that you're not supposed to go past, say, 16, or you're going in too far. Also, if you have medical tape, stuff like that, and you're going to have to continually suction. If you don't remember the number, you can take a quick piece of tape, wrap it around that suction, the flexible suction catheter. So if you set it to the side and you have to use it again, you know exactly where you measure it out at. You don't have to measure every single time. Once again, if you're messing with fluid and substances coming out of a body, always be sure to cover up whatever you can. At an absolute minimum, wear gloves and try to wear eyewear. All AMSs are required to carry eyewear, splash shields, facial mask. It's all a requirement that you go and you dress and you wear all the PPE, just like the folks in this picture here. So you see the person up there at the airway seat, they've got the suction system ready, they've got the Yonker tip on, they got on splash shields and face masks and their gloves, and they're aggressively managing this patient's airway. The goal whenever you are having to suction out is, general rule of thumb, is no more than 10 seconds. I believe in your book now it says 10 to 15 seconds, but if you start going anything longer than that, you could really end up drawing air out of their lungs, causing them to be hypoxic. You can lower their levels of oxygen in their lungs by suctioning all that out, which therein can cause bradycardia and other kind of stimulations. But if that patient is heavily vomiting and they've got a mouth full of everything, you've got to get that stuff cleared out. So if they are continually vomiting, you just continue to suction until you got it out. You just don't need to suction for 20 seconds if it's just light saliva in their mouth. But if they've got a mouth full of stuff, you've got to clear it out. Because if you only suction for 10 seconds and the whole mouth's still full of vomit or blood or whatever, there's still no airflow going through. So you got to clear out that airway. Whenever you do suction, the Yonker tips have, and all the other suction catheters, have a small orifice over where you would put your thumb. So basically you put this in to where you want to start suctioning, then you'll put your thumb over a hole that's on it. So it's almost kind of like the Yonker tip's a flute, where there's little holes you cover up to create different sounds and everything. But on the Yonker tip, there's not going to be any suction created until you cover up that hole, as well as the other catheters. So you'll put it in, you'll place your thumb or your finger over the suctioning orifice, and you'll suction on your way out. Definitively, we always need to be keeping that airway open. It could be a skill, though, that the EMT just can't manage by himself, to where it may be a surgical procedure that a paramedic can do, or you may need medications to help manage that airway. It's very important. Now, the skill set, especially in West Virginia for an EMT to manage an airway, is pretty good. But a paramedic or a doctor at a hospital have a much higher skill set to be very aggressive and manage that airway, more so than the EMT. It's not taking anything away from the EMTs, but it's all about that patient, and there's just a little bit more bag of tricks that physicians and paramedics have to manage that airway. So you just need to be rapidly evaluating that airway all the time. Be looking at, don't ever be looking away thinking that, well, they're going to keep breathing, because the minute you think, they'll be fine, and you look away and start sending Snapchats, the patient quits breathing. So you need to be sure, once you do make that recognition, even in that primary assessment, if the patient is saying those 1-2 word sentences, that may be a good indicator to go ahead and at that point call for a paramedic. Before you do anything else, call for backup, say, I need an extra hand, knowing that the patient just got a bad airway. Some special considerations to be thinking about. So facial injuries. Sorry, had to get a drink of water. So with those facial injuries, anytime there's a major injury, you've twisted an ankle, stowed anything, there's always going to be swelling. So that trauma patient, or the guy who just got his butt kicked outside the bar, got his face pounded in, it's going to have some airway issues. Could be swelling, blood, other stuff in there blocking the airway. Whether it is any kind of fluid or buildup of something, or it could also just be complete swelling from trauma, such as burns, blunt trauma, things like that. If you do get that patient who's ate the wing and the bone at KFC, the suction unit's not going to pull that stuff out. So there's other techniques you have to go into such as the most infamous, the Heimlich maneuver. You got that person doing the universal choking sign, they got their hands wrapped up around their neck. You got to give them the Heimlich maneuver. You got to dislodge that stuff. And that also may mean that if you see something in their mouth, that you just stick your fingers in there and grab it out. Now, paramedics have a little bit more of a skill set with this too, to where they can use some manual devices and go in, lift up their tongue, look down in their throat, and basically take a little small set of tongs and pull stuff out. But you don't ever want to go in digging for gold blind. You only sweep out what you can see with those finger sweeps. With dental appliances such as dentures, partials, things like that, if they're in there good and sturdy, leave them there. Because when we get into talking about manually ventilating a patient, those dentures and stuff, those teeth provide a structure to your face, which will help create a seal and just allow you to aggressively manage the airway a lot better. But if they are a little bit loose and you think when you are managing this airway, if you're going to put an OPA in, you think you can knock a denture loose, go ahead and pull those things out, put them in the patient's pocket, do something with them, just get them out of the airway. Anything that could get loose and obstruct that airway, you need to get rid of. Some pediatric notes. This should be reviews. We've talked about this a few times, but you'll see in the disproportionate big size of the head of the kid, you've got a tongue, and this little kid is the same size as the tongue in this adult. So you got the smaller mouth and the bigger tongue, so anatomically and proportionally their tongues are bigger to the rest of their mouth than adults. Also, all this airway anatomy here is really soft, a lot more pliable, and they got this big dome head and a thin torso. So it creates more of a bind in here laying on their back than an adult does. And also where that's soft, more pliable, it can end up leading to more issues of choking more so than an adult. Just as their airway is soft and pliable, so can be their cervical bones. So you think about that really young kid, you don't want to go manipulate and jerk that head back. We talk about you got those great big old bobblehead babies, and their bones and everything are still healing or developing, so some of them are even still just kind of ligaments. So when you open that airway, it's a slow, gentle movement. You don't want to exaggerate it and push it back too much. So you'll notice when we get more into talking about peds, when you open that airway and you tilt that head backwards, since it got a big bobblehead and a little thin torso, that's going to create a gap under the surface that they're laying on and their back. So it may mean that you have to stuff sheets or something under their back to allow their airway to keep open. Because if not, the moment you open that airway, if you don't pad under their shoulders, that head's going to tilt back down and that airway will close again. Whenever you're putting in an OPA on the pediatric kids, you don't want to put it in the same way you do the adults. The top of that mouth is soft. You can cut it really easy, causing bleeding. So you'll want to use a tongue depressor or use that suction tip, that Yonker catheter, or even your fingers and press down on the tongue and just put the OP in straight. In the same position it will finish whenever you're done, it needs to just go in that straight. There's no twisting motions or anything to it like you would for the adult. So in closing, we'll close with watching some videos of inserting airway adjuncts. If you have any questions, feel free to email me.
When managing the airway of an unresponsive patient without a gag reflex, oropharyngeal airways are a good choice. As always, be certain to wear appropriate